get some ideas for people to develop more research. When I do a review for CGEM, the things that are important to me, and I want you to keep in mind, we always look for good methodology. That goes without saying. However, we also ask the two questions of, is this study important? We'll touch about this in the talk. And finally, will this affect my practice? So if you have good methodology, but the study's not important and it's not going to affect our practice, people aren't really interested in it. Now, to move forward with this, I'm going to bring a fictional research idea that we're going to develop together. I want to say that I do not want to do research on yoga, and I don't want to do research on back pain, but I thought it would be a good vehicle for going over our different ideas. And if anybody's wondering, that is not me doing that yoga pose. So let's say a resident comes up and tells me, I want to do research on acute back pain being treated with yoga. The first thing that should be done is a literature search. And we want to know, do we waste any time or do we spend any time on this topic? And that's why we have Google Scholar, or I have Google Scholar as your first hit. Google Scholar is not going to be an extensive review of the literature by any stretch of the imagination. However, it's going to give you the greatest hits of what's going on. So the artificial intelligence will tell you what has been most searched on this topic. Now, that's not just medical researchers, but just across the whole Google stratosphere. Important because it'll save you time. If there's a landmark paper on back pain and yoga, it's going to be one of the first hits. And you can say, well, listen, this has been studied to death. I don't need to ask this question anymore. Just, I'm going to prescribe or not prescribe yoga for my patients. So you also have to be aware that just because it's your first hit on Google Scholar doesn't mean it's a good study. It just means it's a popular study. And in the era of social media, where fake information and not good information comes out, you have to be aware of it. But it's a good starting off point. Obviously, if you move on to PubMed, it's going to be a more extensive research. It's going to be more extensive, and it's going to be chronological. You're going to see what's most recent with the key terms you said. A bit more involved, but it'll give you a better idea of what's happened recently. When you go to the librarian, obviously the librarian is going to give you the most extensive literature search, and it's good, but you don't want to do it as your first step. So if you have an idea and your librarian gives you 100 articles to read, you may be wasting your time if your Google Scholar search showed that this has already been studied. So as you move along, you want to use your librarian as a resource, but you don't necessarily want to have it as your first stop. And then finally, content experts are obviously a good source of information, but they're not the only source of information. Now, a content expert is good because they'll tell you what has been studied and what may be coming down the research pipeline, what to look for, and they may be able to give you advice of change your question just a little bit. And right off the bat, it's good to have someone like that in your corner to help guide your question. But remember, they don't know everything. They're not as complete necessarily as a librarian. They may be, but you have to assume that there may be some other stuff that they don't know. If we look at the Google Scholar for our fictional question, so it's an example. You can see that with this search, there's a variety of different articles, but they're kind of old. We have 2004, 2013, 2005, so nothing recent. And if you look, you see that it's mostly about chronic back pain. So if we're developing a research idea, we can think, well, it doesn't look like it's been studied. Let's go to our PubMed to see if there's anything more recent. So do a PubMed search and we see, well, there's something relatively recent, 2018, American Family Physician, 2017, Annals of Internal Medicine. And so there are things that have been done. But once again, if you go into detail, the second article is actually a Cochrane review, and they find that it's actually more on chronic back pain. There's some benefit to it, but there's really nothing on acute back pain and yoga. So the question is this a research project? Is this a potential project? I don't know if anybody has any comments on it, but Does anybody think this is something they'd want to jump on? You can add it to the chat or keep radio silence. All right. So personally, with this information, if somebody came to me and they told me that it hasn't been studied, and exactly, so Nina says not necessarily. So there's not enough information. For me, it's kind of boring. And I would still want to know, why is this important? So why is a potential paper important? The things, or a research idea important? The things I want to know, is this a real problem that needs to be addressed? If we have another research idea and it happens once a year in our emergency problem, that's not something I want to really assess. It's not very pertinent to me, and it's not really that interesting, and it's not going to have much of an impact on my practice. As I mentioned at the start, is this going to impact my practice? If it doesn't happen often, it's not. Then the next question, has this already been studied? Well, we've sort of answered that. It doesn't sound like it has been. The next things that are kind of important, or the most important to establish, are there patient-centered outcomes? When we're doing research, it should pretty much all be patient-centered, at least in some part, because our goal as researchers should be to help patients. It shouldn't be to help the economy or department flow. It's about helping patients. So you have to focus on patient-centered outcomes. When you submit an article or a poster, that's one of the first questions they're going to ask. Are there patient-centered outcomes? So that's the most important thing that you have to consider. Now, you also want to hit on a couple of other notes, if you can, with regards to why it is important. Financial implications, not important for everybody, but if you can find an angle that says that the financial implications are important, you're going to get some more people interested in the project. And if it has departmental flow, which ties in with patient-centered outcomes, if you're smart with how you word it, that can also be important. So if we come back to our fictional question, we can see that last year, 2018, there was over close to 2,000 patients that presented with back pain. So that answers our question. Does this happen? Is this important in our world? Yes, we have these people that do this. As we saw before, the studies are mostly on chronic pain, and yoga may be beneficial for chronic pain. So that piques my interest of it. And then back pain is associated with increased depression. That's sort of that's not, it's a patient-centered outcome. So we have to consider that as important. And with the rise of opioid prescriptions, or not the rise, but opioids are often prescribed for this disease process. And we know the high risk of addiction. So we've got two patient-centered outcomes. And this last tidbit comes from an article in JAMA that says 3.2% of Americans missed work due to back pain, and the cost is $61.2 billion. So with this information, I know that it's a real problem in our institutions. There's not a lot of study on it. There's a potential treatment modality that hasn't been studied in the acute setting. We know that there's negative patient outcomes for these patients. They have increased depression, and they have a risk of getting prescribed opioids, which puts them at risk for addiction, and it has a financial impact. So at this point, if somebody came to me with these ideas, I would think, well, okay, it's worth looking into a bit more. So you've got your basic idea for a research project. So the next step is to get your team together. Key members of the team, you and the classic members, you have your principal investigator, your senior investigator, and your collaborators. Principal investigator is the first author, the person who's going to do the most work, develop protocol, analyze data, and so on and so forth. Senior investigator is hopefully someone who has the most knowledge on the topic and most research experience, who can help guide the principal investigator. The collaborators are also important individuals because they will add expert opinion and help along the way. But there's some other people we should think about getting involved in the project. So statisticians, I think we need to get statisticians involved, and in the step of protocol design, I think it's very important to get them involved. So your statistician, you have to understand Some of them will require payment for their service, some will require authorship, and some will have a combination thereof. In my experience, sometimes the statistician will charge for the hours they do in the statistical analysis, but they will help with the writing of the manuscript, the statistics session for authorship. Patient advocates. A lot of residents will be doing retrospective research, and having a patient advocate on board is not necessarily super important. If you can, if it fits in with your protocol, that's good. But when we're doing prospective studies and we're asking for grants, this is very, very important. This is a term that's sort of come up in the last 5 to 10 years as being something that's important. We're talking, we want patient-centered outcomes, and the best person to tell us whether our protocol is going to address patient-centered outcomes is a patient or somebody who knows the patient experience. So with your prospective studies, I really strongly recommend having a patient advocate on board, and they'll help steer you towards a better patient-centered project. Medical students, most of us have used medical students for research purposes, and they're extremely helpful. But should they be part of the list of authors is a question that's asked. Well, to be part of the list of authors, you should have, it is generally understood, you should have participated sufficiently and will take responsibility for the content. Now, your principal investigator, senior investigator, obviously are on that, are doing that, as well as the collaborators. Medical students, sometimes we bring them in just to do the data analysis and or data extraction. And you have to decide early on with your team whether the person doing the data extraction, whether they should be part of the list of collaborators. Are they contributing to the manuscript? Are they doing anything else? So often, if they're just being parachuted in to be data extraction, they're not listed as in the list of authors. That's okay, as long as it's understood up front. But this is still a valuable experience for students. They still get exposed to the research field and the research process, and they can be listed in the list of acknowledgements, and they can still put this on their CV that will help them as they go along. When you're getting involved with medical students, I think the best thing is just to be honest up front what expectations are, and especially with regards to authorship. So you've got a research idea, you've got a research team. Now you have to start working on the PICO question. So just for complete clarity, PICO is P is for patient, intervention, or I is for intervention, C for control, and O is for outcome. You don't have to create your research question with this in this manner. For me, I'm simple. This is a simple way for me to make sure I'm hitting all the bases and making sure we're not missing any important elements when we're developing our question. So if we come back to our back pain, this could be an example of a first draft. So your first draft PICO question, your patients, well, ER patients with back pain, your intervention, yoga exercises, your control is standard therapy, and your outcome is the pain scale. Do people think this is a good PICO question? Do they have questions or comments? I know it's not easy to do the chat, but if anybody has anything to say about this, let me know. So I'd probably say this is a pretty poor first draft of a PICO question. It's getting ideas together, but it's not really very extensive. So Nina brings up a good point. Function is a good idea for outcome, and we'll talk about that in a second. This is a better first or draft of a PICO question for me. So the key elements, so adult patients presenting to the MUHC starting November 1st with back pain, starting within 7 days, no radiologic abnormalities, and no neurovascular compromise. So more complete in that it really defines the patient population, when we're going to go get recruit them. The definition would be better with an end date, but would just leave it with that. It has the exclusion criteria, which are really important for me when I see these types of questions. So no radio No radiologic abnormalities, no neurovascular compromise. The intervention, so yoga exercise, it's a very vague intervention to have a list of yoga exercises, and there's a lot of heterogeneity. However, if we can find a list of exercise approved by a resource like Back Care Canada, so that's a national society that's looking out for patients with back care, it's a lot better. It's got some validity to it, so we want to use that as opposed to just random yoga exercises. The control of standard therapy is pretty good. And so that brings up a question for the intervention. Should we define the hours of treatment and number of sessions? I think that would go in the protocol. I think when you're developing the question, really important to have that in mind. But in the space of a PowerPoint slide, there's only so many things. But yeah, so when you're doing your intervention, it has to be detailed quite a bit. How many times, or the nature of the exercises, the frequency of the exercises, and the duration of it. And if you come to the outcome, you'll see something called the Austria Low Back Pain Questionnaire. This is something I just found doing the brief literature search. I'm not saying that we should be using this, but the important thing, this is a tool or a questionnaire that was used in a lot of the studies I looked at. So it's a validated tool. It's been used in other projects. So I think that's a valid tool as opposed to just a random pain scale. Nina mentioned function would be a good outcome also, but you have to assess, find a good tool to assess outcome. So you want a validated tool, if you can, that can be used, and it's got very little inter-rater variability. I also like to put the secondary outcomes in our in our drafts of the PICO question. So secondary outcomes such as lost work days, number of opioid pain relievers, things like that, I think are helpful to have as part of the PICO question. So I've got my research idea, I've assembled my research team, I've got a more complete PICO question, ready to move on to the next step for me, which would be feasibility. It's great to have it's awesome when you have a great idea, but if you can't pull it off, then you're wasting your time. And it's, once again, as I talked about with our lit search, if this has already been done, you don't want to do it. If it's impossible, you can complete this study the way you want to do it, then you shouldn't do it. We'll talk quickly about sample size, the time, the data that you can get, as well as some patient factors. Sample size. Now, I am not a statistician. I'm not mathematically minded. I should not even be talking about stats. However, it's very, very important to acknowledge this component. If you are presenting a research project, if you're presenting at Quebec Research Day, if you have a poster, if you're submitting to a journal and there is no mention of sample size, it's no go, no bueno. This is something that you have to have done. It's a bare minimum to walk in the door. I'm going to give you a brief overview of some of the main concepts. I'm not going to go with statistical formulas because they confuse me, but we're going to talk about this. Now, when you can't always do a sample size calculation, so you sometimes have to do a convenience sample. An example of this is Caroline, who just graduated. She did a study on Ironman patients or Ironman participants and EKGs. And there's only so many EKGs you can do on Ironman while they're waiting to register. So that's a convenience sample. When this was presented, though, some of the reviewers at the Quebec Research Day, some of the reviewers said, well, you can try and extrapolate a sample size by various techniques that would just acknowledge that you thought about it, but you weren't able to do it because of the convenience sample format. If there's absolutely no information on what you're studying, you can start off with a pilot study to sort of establish some of the parameters that you're going to use for your sample size calculation. Now, these different elements that I've listed here that I'm going to go over in a second, this is what you need to be able to do your sample size calculation. You don't have to know how to do it, but you have to know this information to be able to move forward. And once you have this information, you can go to a statistician or you can use free software like the UBC sample size calculator, but you need to get these elements. So, level of significance. This is our alpha or type 1 error, which is stating that there's a difference when there's no difference present, so a false positive. This is our p-value. We usually set it at 0.05. So that is pretty standard. You don't have to go search that out. That's what people use pretty much as standard. Power. Power is your type 2 error or your beta error, and that's failing to show a difference when difference truly exists, so a false negative. Also, you don't really have to search this one out. You have to just decide with your senior investigator. Often said it's 80%. The event rate is a mean of the whatever you are measuring. We'll go over that a bit more in detail when we talk about our fictional case. Standard deviation is of that event rate, and then the effect size. That's should be a size that's estimated based on previous studies or your pilot study. If we come to our fictional research question, so as mentioned, we want a level of significance of 5%. We want a power of 80%, and we're looking for an event rate. So our event rate is the average pain score. We had our outcome as the pain score at 7 days. So we would get the average pain score of those patients at 7 days to be able to establish their sample size, standard deviation of that pain score, and then the effect size. So we would go back to the literature with the previous Oswetry pain scales, and we would see what the different studies have shown as a significant change in the past and use that to guide us. So for example, if a pharmacologic agent was used to assess treatments in back pain and they felt that a 15% change in the score or a 15-point change in the score was significant, we would figure out if they had that as a validated source and we would use that. So once you get that information, my recommendation, go to the statistician and they will put it in their formulas and they'll be able to come up with it. But really important to address sample size, even if you don't understand 100% what it is or how you calculate it, very, very important moving forward. And it's important as the feasibility component, because if you have to get too many patients to get a significant result, you may not be able to do the study. Time. So with this group, you have to figure out what you're doing this for. So many of you, it's going to be a residency requirement. So you can't go on a huge prospective study that's going to take 6 years to accomplish. If you're presenting at a conference, you have to do something super, well, not super quick, but you have to have that in mind about when you're going to do it. But if you're a career researcher and your time is on your side, you can do these big projects. But just be aware of where you're heading and being able to tailor your project so that you'll accomplish your goals, because a half-finished project sucks. Data sources. Well, if we're doing our prospective study, we are going to get a lot of the data from our patient and our patient interactions and our clinic case report form. But a lot of you are going to do retrospective, and even with the prospective, you're going to need to go into the chart a bit. So one of the key tools that we use at McGill and MUHC is Oasis. So Oasis has a lot of information. It's basically the digital chart. So you're going to go in and extract information for that. If this is your only data source, it's got to be for a small project. So a small project where you're looking at 8 or 10 cases, something to that effect. Otherwise, in my experience, I don't have a good extraction tool for getting a lot of data out of that. And we're working on improving that, but right now that's our reality. Another data source that we use at MUHC is MEDURG. So this is some data extracted from MEDURG using the analyzer module. At the MUHC, there's a couple of people that are familiar with using this this module. So there's myself, there's Mark Bake, Anthony Robert. I know at the Jewish, there's Zhao King, the research assistant that's very familiar with it. And the wonderful thing about MEDURG is there's a lot of data in it, and we're sort of trying to figure out how to extract it and how to use it. And we're getting better. But this is an example of some of the data you can get out of MEDURG. So obviously, this is for a COVID study that we're doing. And this is data from the 16th of March earlier this year. So you see, we obviously get the patient ID when they arrived. The length of stay is automatically calculated. If they passed away in the emerge, we can access that patient demographics information such as age, gender, how they presented, We see a flu score calculation here. There's CTAS or triage level score, as well as their final diagnosis. There's other information that are easily accessible, such as whether they were admitted, tests that they were done. So there's a lot of information that you can get out of there. So it's a really useful tool. And if you're doing retrospective stuff, come see me or see Xiaoqing at the Jewish. There's a lot of things we can get. And, you know, it's hard to explain it in a quick slide, what you can get out of it, but there's lots of information out there. There's also data warehouses. I believe there's, I'm not sure how the access is at the Jewish, but the data warehouse at the MUHC is sort of coming online. We're working with them to use it for some of our projects. It's not a robust process at this time. In theory, this will be the best way to do big data studies with lots of key points, but right now it's not yet good, or it's not the viable option for our current research needs. Once you get your data or your data sources, you want to see if it's clean, because if you have to clean the data too much after you extract it, it's not feasible. So what does cleaning the data mean? You're going to look at your data points and see if there's missing data, duplicate data, or things that are not right. So for example, on this extracted data, you can see that there's two patient identifiers, patients that are the same. So you have to go in and eliminate one of them, or else your data is not as valid. So important to consider the data, cleaning the data before you decide on your data source and whether your project is feasible. Then we come up to patient elements. So it's great to have a great idea of your data source, and if you're going prospective, can you recruit enough patients? If you have really high recruitment numbers and you have a limited time, no, you're not going to be able to. How will we identify and recruit patients? This is a key element. Now, previously, some learners have come up and said, well, we'll just ask the eMERGE doc to identify patients for our study. Not a feasible option. Docs are busy and they don't have time, and so be mindful of that. One of the things that came up during COVID also is we can't have research assistants walking in the room and exposing themselves to COVID. So we had to figure out a way, and then phone consent is a big thing now that we're using. Will the patient be willing to participate? If you've got a 3-question CRF that you ask the patient while they're waiting for tests or while they're in the department, you're likely to have a high response rate. If you have a 100-question CRF that you want them to answer, you are unlikely. So be aware that the more involved the patient has to be in the extracting the data, the less likely they'll be willing to do it, and that may affect your feasibility. And obviously, if this harms the patient, you want to be aware of that. And you know, we don't want to harm the patients, obviously, but just an extension of the will this harm the patient, you have to consider, will this prolong their stay in the emergency department? And if it does, they may not want to participate. So you've got your research idea that you've turned into a research question that you've assessed as feasible. Now you have to develop your protocol. I'm not going to go into detail other than outlining the different things. Your research supervisor should be able to provide you with this. And if not, you can talk to me. But a lot of this stuff was already covered in your PICO question. So your background information, your aims, your study design and methods, inclusion exclusion criteria, your outcomes, your statistical analysis, including sample size, patient safety, funding, dissemination of results. So those are the basic elements of your protocol. Pretty straightforward. And as I mentioned, you should be able to have all of this from your PICO question if you did a good job at your PICO question. So Nagano. In Quebec, we have an online, or most institutions have an online ethics submission process. It's present at most research centers across Quebec, which allows some convenience of communicating between centers, especially if you have a multi-centered trial. So what you need to do to get involved with Nagano, so you've got your protocol, you want to submit it. You have to go to, if you're doing it at McGill, the MUHC Nagano site, and you see at the bottom, there's an email. So you will submit your contact information to that person. You'll say who your supervisor is, and you will get a Nagano account. Your supervisor, at least at the MUHC, needs to have Research Institute privileges. So when you're establishing your team, you have to keep that in mind. Does my supervisor have Research Institute credentials? And if not, we have to find someone else who does to be a member of the team. And then if you've done your homework and you've done your good PICO question, filling out these forms are quite easy. This is what it pretty much looks like once you've created a file. You have general information about the study, and the green triangles on the right are fields that you need to fill in. So obviously study title, location, very basic stuff. Project description, so MSS research category, that is asking if this is a study on therapeutics or epidemiology, investigations. You go down, experimental design is whether it's a case control, randomized controlled trial, or single blind, double blind. So pretty basic stuff that you should all have easily accessed. Then there's a section on recruitment, the recruitment process and consents. If you don't have a consent form, which a proper consent form is kind of tough to create, you go to Nagano and they will guide you on how to create your consent form. Different sections, you also have questions about data access, protection of information. You will need DPS authorization. So you don't have to go out and search out DPS authorization when you submit in Nagano. At least at MUHC, they will send a summary to the DPS to approve this. Many studies also required a approval approval of the chief or the research director. Estrabag asks if this is the same form for McGill. Unfortunately, it is not. So this is mostly done for clinical research. The McGill one, if I'm not mistaken, is still a paper process. So last time I submitted a McGill ethics submission, I had to make 10 copies of all the documents that you're having online here, which is tedious, and you could argue that in the era of COVID, it's kind of silly, but that's the difference between the McGill ethics proposal. And the reason you would go with a McGill as opposed to hospital-based like the MUHC or the Jewish, if there's no patients involved, if you're doing a study, let's say for a sporting event, then you may want to go to McGill because it's not really involving MUHC patients. And then finally, we can talk about the project files. Obviously, you can submit your research protocol. And then the last element of all of this is you have to sign it to say that you're going to adhere to stringent research criteria and do good research. So brief overview of how I would like somebody to come to me with a research idea or research question. Like I said, this is my approach. Other people may have other thoughts on this, but like I said, I think if you have an idea, start off with a Google search to find out if this is been studied to death. If you don't see that's the case, do a bit more involved. Let's search with PubMed or the librarian. Establish why it's important by telling me that it's a real problem in our institutions. It hasn't been studied. There's patient-centered outcomes that need to be addressed. There may even be some financial and flow outcomes that are important. Assemble your research team. Be clear about roles, including senior and principal author. If you have medical students on, be clear with them whether they're going to be a part of the list of authors. Come up with a detailed PICO question. The detailed PICO question at the start is going to be very important. As you see at the other steps of the process, you will be able to easily fill them in. And feasibility is a very important one. Do not come to me without thinking about sample size. Sample size is so important. And if you don't have an even thought on that, you're not going to be able to move forward. Think about the time you have to complete the project. Think about your data sources. How are you going to access them? Are they clean sources of data? And so be aware of that. Think about your patients. Are they going to be willing to consent to these projects? Are you going to be able to consent? Someone mentions that be aware of how long the ethics process takes. Yes. So when you're creating your project, sometimes ethics can be really slow. And right now in the era of COVID at the MUHC, they're prioritizing COVID related research. So you have to be aware of that. So feasibility, develop your protocol, do your ethics submission, and start gathering data. So that's pretty much what I had to say about developing a research question. If you guys have any questions, please let me know. If you want to talk about it in detail, come see me or email me. I'm quite available. And to reiterate, I do not want to do research on back pain or yoga. And that's it.
Great, thank you. Thank you so much. I'll just take this chance to